Welcome again to the pathology series. Today we'll be speaking about principles of neoplasia. A neoplasm is a new mass, a new growth. This occurs due to multiplication of cells in a response to either inflammatory activity or because there is a tumorigenesis happening. Tumor cells have an altered mitotic machinery and they exploit different mechanisms to ensure growth and rapid multiplication. Cancer is a genetic disorder caused by DNA mutations. These either can be induced by the exposure of mutagens or they occur spontaneously due to a large number of replications, such as in the aging process. Chronic inflammation or chronic disease it also can induce cancer due to the excess turnover that happens in these situations. To the process of tumorigenesis, we can include failure of growth-regulating properties due to an altered gene expression or growth-regulating signals. Some examples include failure in the DNA repair mechanisms and other common types of non-random structural abnormalities in the chromosome of tumor cells, such as balance translocations, deletions, cytogenetic manifestations of gene amplification, and others. There are two types of genes which can be affected, either proto-oncogenes, which affect the tumor cells by gaining of function mutation, and these are genes encoding for proteins that promote growth, promote signals to attract other types of cells such as blood vessels or angiogenic signals or inflammatory cells, fibroblasts and other stromal tissue cells. On the other hand, in tumor suppressor genes, the tumor phenotype is expressed by loss of function mutation in anti-proliferative substances or pathways, such as P53 or RB protein, P16. The latter, for example, it's an inhibitor of cyclin-dependent kinase. Genetic evolution and selection explain two of the most pernicious properties of cancer. This means that the cancers that appear later in, for example, that period of metastasis would be different from the cells that are present at the beginning. In some tumors, their growth is produced due to the action of hormones that stimulate growth and replication, such as estrogens in breast cancer or uterine ovarian tumors. As we said before, frequently tumor sites are sites of chronic inflammation. After cell injury, replication and turnover of tissue cells happen, hence there is a bigger chance of replication errors in the mitotic process. An example is esophageal adenocarcinoma after prolonged GERD. The squamous epithelium performs metaplasia to mucus-producing cells that are a better insulator of the acidic material. Precursor lesions are neoplastic lesions that could be malignant. For epithelial tumors of hollow organs, we speak about intraepithelial neoplasias. These can be graded from 1 to 3 usually, depending on the length of the aberrant cell layer versus the normal cell layer. Preneoplastic lesions occur at sites of chronic inflammations or chronic tissue injury. Some tumors tend to look similar to pluripotent tissue and are able to hijack the DNA genetic information to exploit replication properties as well as production of growth factors. Growth factors are really important to keep the replication process of tumor cells and also to keep recruiting new cells around them that provide them of nutritive properties. There are two tissue components of the tumor, the parenchyma, which are transformed or neoplastic cells, and the stroma, which are supporting or host-derived non-neoplastic elements, such as connective tissue, blood vessels, and inflammatory cells. According to their tissue of origin, we can divide neoplasms into epithelial tumors, which are tumors that derive from endodermal layers that give rise to epithelia. It means the lining of the GI tract, the respiratory tract, urinary tract, and the parenchyma of the corresponding organs of these systems. And they give rise to adenomas or squamous cell carcinoma, adenocarcinomas, and such. There are also mesenchymal tumors, which are tumors that are derived from mesenchyme, including bone, muscle, and connective tissue components. They give rise to, for example, osteomas or myomas, fibromas, and their malignant counterparts, which usually end with the suffix sarcoma. There are also mixed tumors which share properties with both of them. According to their behavior, we can divide neoplasms into benign or malignant. Benign neoplasms, they do not behave aggressively. They do not produce tissue necrosis and do not metastasize or spread to different organs. They're usually encapsulated, but there are some examples of tumors that are benign and they are not. For example, is leiomyoma. The suffix oma is frequently used to describe benign neoplasms. For example, adenoma, which means benign glandular tumor. An exception to this rule is mesothelioma, which is a malignant tumor of mesothelial cells. Mesotheliomas are always malignant. Other few examples are melanomas and such. Malignant neoplasms, on the other hand, are not encapsulated. They also produce tissue necrosis, usually ischemic necrosis due to new accumulation of cells which don't have enough nutrient supply. So they produce degradative enzymes which dissolve the basal lamina and underlying connective tissues and are able to metastasize to other organs after reaching the vasculature or the lymph node or by porogenous spreading. On a histology slide, we can differentiate some features of neoplasms that can tell us that the cells can have an aggressive behavior. For example, anaplasia. Anaplasia means loss of differentiation. Cells, they start becoming pleomorphic. There is anaplastic nuclei, which are bizarre and they're variable in size and shape. There are also mitotic or nuclear abnormalities such as nuclear atypias or hyperchromatic nuclei, increased nuclear cytoplasmic ratio, coarse and clump chromatin, numerous atypical mitosis with tripolar or quadripolar spindles. Other reactive changes can also be precursor to malignant lesions such as hyperplasia or metaplasia. The main features that differentiate benign from malignant neoplasms is the rate of growth, which malignant tumors do much faster, and local invasion of surrounding tissues and metastasis. Tumor spreading occurs by growth of the primary lesion. In the case of epithelial tumors, we speak about intraepithelial neoplasias. These are precancerous lesions which later grow beneath the basal lamina. There is dissolution of the cellular connections, there is loss of tissue architecture, and invasion of the extracellular elements by degradative enzymes. Then there is progressive infiltration, destruction and penetration of the surrounding tissue, invasion of the adjacent cells and tissue elements, and spread through the blood, lymphatic vessels, or adjacently to other organs that nest in a secondary tumor. This latter process described is called metastasis. There are three ways of metastasis. Hematogenous, it means through the bloodstream, and cells that do this typically nest in organs such as brain, lung, bones, and liver. Also, most sarcomas do metastasize in this way. There is also lymphogenous, which means through the lymph nodes. In this way, the initial tumor site invades regional lymph nodes according to their location of lymphatic drainage. This knowledge is useful in diagnostic settings since you can find sentinel lymph nodes in order to evaluate cancer grading and staging. Regional lymph node biopsy can be performed too. Also, most carcinomas, they metastasize lymphogenously. And there is porogenous spread. This means that the tumor cells spread to adjacent tissue through serous membranes or through canalicular spaces such as the bile ducts. This is typical for adenocarcinomas or ovarian tumors, for example. The metastatic process is usually a combination of the processes previously described. Frequently, tumors they recruit new blood vessels via the release of growth factors such as vascular endothelial growth factor or platelet-derived growth factor and form neovascularization to supply their nutrient requirements. Tumors have an altered metabolism, especially their malignant counterparts. The malignant neoplasms exploit a mechanism known as Warburg effect. Counterintuitively, tumor cells gather energy through anaerobic glycolysis, even though it is a very inefficient energy supply mechanism for their increased requirement. They do this in order to produce energy faster. This makes the surrounding tissue and systemic nutrient support compromised. One of the frequent symptoms which cancer patients present is weight loss. In cancer, there is an increased BMR, basal metabolic rate, despite the decreased appetite, which is not normal compared to starvation, in which in an starvation phase the BMR will decrease as the food intake decreases as well. Some tumors they also exhibit paraneoplastic syndrome. These tumors they act as endocrine glands and they produce substances that cause a variety of symptoms, such as a procoagulant state with mucinous adenocarcinomas, or production of ACTH, or a substance that acts like ACTH by small cell lung carcinomas. Some other tumors they also produce like antibodies against acetylcholine by, for example, thymomas, and some other types of various abnormalities that express in a wide variety of symptoms. Incidence of cancer varies with age, but also with race or geographic factors and genetic background. Some environmental exposures also put the individual to susceptibility of getting cancers, like, for example, smoking and lung cancer. It is said that cancer affects the two extremities of life, either when people are very old or when people are very young. This is kind of true, but it can also affect people in between age groups. Melanoma has its highest incidence in Australia, or, for example, gastric cancer has a very high incidence in Japan. And these are due to different environmental differences that are in these places. For the Australians, they have a fair skin and a lot of sun exposure. And for the Japanese, they eat many more smoked foods, and this affects their gut in another way. Cancer is one of the most common causes of death. Perhaps it is the leading cause after cardiovascular disease. There are 8 recognized hallmarks of cancers and some emerging hallmarks and enabling characteristics. In the following slide, we can see some signals that are mutated in cancer process. In the growth factor independence part, for example, we can see a group of mitogen-associated protein kinases, either coding for receptors or parts of the protein of the pathway. These are pathways that render cells into mitosis after obtaining a receptor stimulation. Other signals are related to immune regulation properties or pathways to evade apoptosis, pathways to signal with blood vessels and induce angiogenesis, coding for proteins that are degradative in order to invade the surrounding tissue, such as the MMPs, and dysregulation of replicative regulators, such as P53, for example, that is the so-called guardian of the genome. Many of these substances, they participate in regulation of the cell cycle, so that's why in many textbooks they also tend to review it. In the following slides, I've done a classification of tumors by either organ system or by organ. Diagnosis of a neoplasm can include many types of imaging techniques to localize the mass, and the main goal should be to obtain a tissue biopsy and confirm the diagnosis by the pathologist. Superficial tumors can be localized by ultrasound after inspection. Frequently, the mass that is visible is not the primary tumor per se, but a lymphadenopathy, a reactive lymphadenopathy caused by the invasion of the tumor cells into the regional lymph node. A lymphadenopathy in this case is painless. It tends to be tender or rubbery. And a lymphadenopathy that is due to infection is usually painful and can be red in color. CT or MRI are also frequently used in oncology. A very useful method is the use of PET-CT, which is exploiting the high metabolic activity of tumor cells in order to increase the uptake of some radiolabeled material such as deoxyfluoroglucose. So the tumor cells that are then exhibited to the gamma camera, and the lesions can be localized in the body. Here you can see a metastatic ovarian carcinoma in picture A. Ultrasound of the liver with a benign liver tumor is just beneath it. On the bottom left there is an endoscopy with narrowband imaging of the esophagus in a patient with esophageal cancer. In narrowband imaging you are able to identify the blood vessels that run through the channel you are seeking. On the bottom right you can see an X-ray of a patient with lung cancer, squamous cell carcinoma, and a CT of a coronal section of the same patient. Top right is a sentinel lymph node biopsy of a breast cancer. Cytology can also give us important clues of the nature of the neoplastic cells. A pap smear or Papa Nicolau smear is the name of a screening test used to identify cervical intraepithelial neoplasias. A small portion of epithelia is taken by a brush and stained to look to the cells under the microscope. In FNAC or fine needle aspiration cytology is another method which withdraws tumor cells from the organ to be examined under the microscope. Intraepithelial neoplasia and carcinoma in situ are precursor lesions to cancer. These two terms are used to define tumors that have not invaded the underlying basal lamina but could have an aggressive behavior. Tumor cells display a new repertoire of antigens and receptors which can be targeted via immunophenotyping. It means that the use of immunohistochemistry and labeling of the desired structures with fluorescent antibodies or antibodies linked to special enzymes such as horseradish peroxidase, which change color, could be used in order to make tumor cells be displayed under the microscope. Some other methods are also hybridization methods or genetic molecular methods, which can be used in cancer diagnostic process. In hematology, fluorescent in situ hybridization is frequently used, as well as flow cytometry. Before mentioned biopsy is sentinel lymph node biopsy. It consists in injecting the tumor site a radionuclide labeled and color material, and then you wait until the regional lymph node drains it and the lymph node is resected by surgery. The presence of malignant cells in these sentinel lymph nodes has important value in breast cancer prognosis and treatment plan. After diagnosis, a multidisciplinary team participates in tumor grading and tumor staging. Tumor grading describes how abnormal the cells and tissue look under the microscope when compared to healthy cells. Cancer cells that look less differentiated tend to behave more aggressively. It is performed by the pathologist, since cells are evaluated under microscope from tissue biopsy. Staging of cancers, it consists on localizing the cancer and assessing its size and if so lymph node or organ metastasis has occurred. This is usually performed after several imaging studies, and it's a multidisciplinary approach. More modern tumor evaluation techniques include evaluation of proteomic images or microarray images, which belong to the evaluation of gene expression of the tumors. Cancer therapy can very different. The cancer is not exactly one disease, but rather a group of disorders that share a profound growth dysregulation. Some cancers are really curable, but others are virtually always fatal. Several options exist to treat a cancer. A brief summary is displayed in the following slide, which could be a topic for another video. Thank you for your attention. I would love your feedback down below, and see you. Have a good one.